of dentine using any of the 4 different nickel titanium systems was untouched by the instrument. This was confirmed by multiple different studies, like this study by this group, which was published in the International Endodontic Journal, again in 2001, and they say that after balance force and lateral condensation, the oval recesses in 40% of oval canals, like the ones we are seeing here, these are what we call the recess, which is the area away from the instrument. The instrument was working here and maybe here, but it didn't touch this part. So oval canals, we have to pay a lot of attention. We need to end up with something like that. That's now the instruments are touching as much as we can from the dentine surface. I know that I'm taking things to be very much complicated, but I'm furnishing a background for what's coming later and the importance of what we are going to discuss later today. So the 5th challenge that we are facing is that root canal infections are not similar to types to any other infection in the rest of the body. Why is that? Because I don't have immunological help, because there's no blood supply in these teeth. So there's no immunological cells, there's no immunological reaction which can help me to fight this infection. And as far as I don't have blood supply, then if I'm going to give systemic antibiotics, nothing is going to change the case. I can give systemic antibiotic to change the systemic condition of the patient from being in the acute phase to the chronic phase. But does systemic antibiotics can heal endodontic infections? Definitely no. It doesn't reach the root canal. So, what should we do? How can we face these challenges? First, mechanical instrumentation, which I'm not going to touch this morning at all. I'm going to focus mostly on chemical measures. We have to adopt chemical measures in the proper way during our root canal treatment. It's not just the type of the irrigant, it's the method of irrigation. And my colleague, Dr. Pete, in the previous presentation, he did touch on this part lightly. Maybe I will spend a little bit more time in it. However, we need to focus on this part and concentrate on it this morning. Types of irrigation. So, do all irrigants have the same effect? Definitely no. If you want to get a list of the irrigants that we use in endodontics, you'll find that we can fill out 1 or 2 pages. However, I'm going to just 4 irrigants that we deal with nowadays. Hypochlorite, sodium hypochlorite. That's an old irrigant that we have been using for over, I would say, it's not over, it's 100 years exactly, since the invention by Dakin, or the start of the use with the sodium hypochlorite by Dakin in the First World War in 1916. Then, now it's been 100 years with using it, and we are still using it. Then we have Editor, which I don't consider very much using it by itself is an enough irrigant because it's a weak antimicrobial agent. However, we can use it in conjugation with other irrigants like the sodium hypochlorite if you are interested in removing the smear layer, and I'm going to focus on this later on. Then we have the chlorhexidine gluconate. That's a nice irrigant, which I use it interchangeably with the sodium hypochlorite. And finally, maybe the new member of the family, it's not that new, however, there's nothing came newer than it, so it's still the new or the recent irrigants. It's been around for over 10 years now, however, we didn't see any other irrigants recently. So, the BioPure that. Hypochlorite, I'm not going to talk a lot about it. Most of you, if you are practicing endodontics, you know it quite well, and most of us, we are still using it. It's the current irrigant of choice, and it's an effective antimicrobial agent, organic tissue solvent, and maybe that's the most important organic dish solvent that we know, lubricants, and it acts very quickly and effectively. Concentrations 0.5 to 5.25. We used to focus a lot on the concentration in the past, and we would say that we would like to go for a full concentration. However, most of the studies have shown that you can go to half the concentration, 2.5%, or maybe even lesser or lower than the 2.5. You can go to down to 1.5 or maybe 1% of the sodium hypochlorite. However, you have to compensate this concentration with the volume, and I'm going to focus on this point a little bit later. According to these studies, the most critical for disinfection than its concentration is the volume. That's what I was just mentioning right now. And the frequent exchange and use of large amounts of the irrigant, it can compensate quite well for the lower concentration. What is the volume? How much volume? The normal irrigating syringe is that you use in your clinic is 3 milliliter, maybe 5 milliliter. I would say that you would use during your mechanical preparation not less than 3 fills, which means that not less than 10 milliliter, and maybe you can go up to 15 milliliter. You have to fill your syringe 3 times during your mechanical preparation to say that you are having a good volume. It's not just few drops. So you need to do quite good washing for the root canal. Limitations, definitely there's a lot of limitation. None of us would like to see this picture, which is what we call a hypochlorite accident. And this happens when you apply your irrigation under pressure, so you are forcing the irrigant outside the tooth in the periapical area. Patients can develop some bizarre actions like this. The statistics say that if you are an endodontist, you might face one of these cases with your patients, with this what we call hypochlorite accident once in your clinical or practical life. I already had my share. I already had one of my patients done this. I hope I wouldn't go beyond the statistics. Anyway, limitations, it's sometimes people would like to say that it's not effective against E. faecalis. Let me talk just a few seconds about the E. faecalis. E. faecalis is an important microorganism that we deal with, especially in the retreatment cases. If you have a failing root canal treatment, the major player in these cases is what we call the E. faecalis. That's a microorganism which is very resistant, and unluckily sodium hypochlorite is not that efficient against this. What's efficient against it? Chlorhexidine gluconate. That's another irrigant that I'm going to present now. So, chlorhexidine gluconate, it's effective against resistant strains and basically the E. faecalis. That's another property in the chlorhexidine gluconate that's very important, is that its action inside the root canal, it stays a little bit longer. The hypochlorite, its action ends just a few minutes after you finish up what you are doing. However, the chlorhexidine gluconate, most of the studies have found out that it can stay even a little bit longer, reaching a few days. It not opposite to the hypochlorite, it have a very low toxicity, and that's an important property for the chlorhexidine gluconate. Where can you get the chlorhexidine gluconate? You can buy it. It's present in the dental depots, or maybe if you don't want to or you don't have an access, you can use a mouthwash. There's some mouthwashes in the market which are basically chlorhexidine gluconate. If you want me to give you some names like what we call hexatol or antiseptol, these are the commercial names for some mouthwashes. However, the concentration of the chlorhexidine in these mouthwashes is a little bit lower than we want to. It's around 1%, and we would like to go for 2%. However, still, the volume can compensate for the concentration. So, chlorhexidine gluconate is a good alternative for sodium hypochlorite. However, I would like to tell you that it doesn't have the ability to remove the smear layer, and it doesn't have the ability to dissolve tissues. So if I'm dealing with a vital case in which I'm expecting to have vital tissues inside my root canal, I would definitely go for sodium hypochlorite. However, in non-vital cases, I can alternate between sodium hypochlorite and chlorhexidine. And in retreatment cases, definitely I would go for chlorhexidine gluconate right away. I wouldn't use hypochlorite a lot. Some people would like to combine, and when we talk about combination, we are not talking about you are adding this to that. When we are talking about combining two elegants, we don't add them to each other. We use them alternatively. That's what we mean by combination, which means that if you put the chlorhexidine gluconate, if you add it to the sodium hypochlorite, you lose the antimicrobial action of both of them. And they form what we call a precipitate. And when you try it in your clinic tonight, get some sodium hypochlorite, add to it some chlorhexidine gluconate, you'll find that inside the syringe there is a precipitate, and when you try to inject, it doesn't come out because it clogs inside the needle. So we are not talking in combination by combining them together. We are talking about alternating. Use one and then we use the other. We go to the MTAD. This was presented by Professor Torabinjad from Loma Linda University. And it's a combination of tetracycline and an acid and a detergent. Let me just make a note here about the tetracycline, because now we are starting to see an antibiotic in the root canal. Because all the others, we are not talking about antibiotics, we are talking about solutions which doesn't have antimicrobial action, but now tetracycline appeared, and we're going to touch on this again later on. Then we have an acid to help us dissolve the tissues, the vital tissues, and then we have a detergent so that it can clean the walls. So basically, this combination seems to be working in a good way, and studies have shown that it does have a good antimicrobial action. It's effective against E. faecalis because tetracycline is a strong antimicrobial agent, and it does have the ability to remove the smear layer because there is a detergent and there is an acid, and both of them, they can work on the organic and the inorganic components of the smear layer. So, talking about smear layer, do we need to remove the smear layer, or we doesn't need to remove the smear layer? Basically, I have to tell you that the smear layer is loaded with microorganisms. You all have to know this. And it prevents adhesion to the dentine because it forms a layer which is going to present the chemical changes that you'd like to make to the dentine so that the bond can form a hybrid layer. And the microorganisms inside the dentinal tubules, they are hiding under the smear layer. However, on the other side, some people would like to look at the smear